Welcome to everyone. Thank you for joining us at the 3rd Annual Women in Wellness. Please turn off your cell phones if you haven't already. I'm Meryl Braylauer, and I'm delighted to be hosting you at the Dreamland this year. After more than 40 years of coming to the Dreamland, I can't believe I'm on stage. And it's great to see all of you from here. Okay, how many of you have been to Women in Wellness before? Raise your hand. Okay. How many of you are new? Okay. We're here tonight to celebrate our new hospital and to showcase our hospital's connection to Mass General Hospital in Boston through telehealth and specifically with stroke. We'll also introduce you to palliative care, so important for patients and their families and very different from hospice. How many of you been to the new hospital? Raise your hand. Oh, a lot of you. Whoa, great.
It's not so great.
Well, depends how you get there. One way to get there is to visit the ER, like I did. My doctor at home was afraid that I had pneumonia. Too many movies at the film festival and not enough sleep. At the film festival here, actually, in this room. He wanted me to get checked out. And of course, it was a gorgeous day, and I was less than thrilled to have to go to the hospital. Honestly, I wasn't sure where to start. Do I go to the ER? Do I go to the walk-in? So I went up to the greeter and asked him, and he said, well, why don't you stay at the ER in case you need an x-ray? So I did. I can't even tell you how helpful and efficient everybody was. The ER examining room was lovely, super private, totally state-of-the-art. Start to finish, it took less than an hour, and I didn't have pneumonia, so I was very happy. One of our hospital's major fundraisers, you've heard of Bruce Purcellay, I'm sure, recently joked that people have heard how beautiful the hospital is and are making reservations. You don't have to be sick or have a broken bone to check it out. Come have lunch in their lovely cafeteria. It's less crowded than town, and there's easy parking. Every year, you hear us say 80% of all healthcare decisions are made by women. We are here today to present you with the most up-to-date information so that you, as the decision makers, can make the best possible decisions for yourselves and for your families. Next, my co-host, Gail Camolier.
Good afternoon. I'm Gail Camolier, and I'm one of the 4 co-hosts working along with Meryl. And it's my pleasure to, first of all, thank our sponsors. I think you've seen the names scrolling on the screen when you came in. And we want to thank each and every one of you, and we could not do this without all of your support. So it's my pleasure to introduce our distinguished speakers today. The first one is Dr. Lee Schwalm, immediately to my left. Dr. Schwalm is the Executive Vice Chairman of the Department of Neurology. He's also the Director of the Comprehensive Stroke Center, and he's Director of the Center for Telehealth at Mass General. Telemedical technology offers a critical link for us to the vast resources available at MGH, so I'm excited to hear how all of that works. We asked our presenters today to tell us a little something about them that we wouldn't normally know in just reading their bio. How many of you remember a television show back in the 60s called To Tell the Truth? Let me just tell you, this guy would have won. So the first job Dr. Schwalm had, and you can't make this up, was working as a sound man on a traveling rodeo outside of LA. Right.
True.
That's true. So I just want to say to all of you who have 20-somethings and 30-somethings who are maybe not following the path that you had envisioned for them,
Don't worry.
there's still hope. Well, following Dr. Schwalm's presentation, Dr. Faith Frabel, who is the director of the Nantucket Cottage Hospital Emergency Department, will make some remarks. Then we'll move on to our second presenter, Dr. Vicki Jackson, who is the chief of the Division of Palliative Care at MGH. And she'll be presenting on living with serious illness and how palliative care and hospice differ. Now, this is another little factoid that she shared with us that I'm not sure she would admit to in Boston, but she is a ferocious Green Bay Packers fan. She's a native of northern Wisconsin, and I find this fascinating. The people that she works with now at MGH are 5 times more than the town she grew up in. So that must have been pretty small. Pretty small. And among those employees is a canine employee named Doris. So I hope you'll share with us a little Doris story. Following Dr. Jackson's presentation, we're going to hear from Diane Bean, who is the program director and nurse practitioner of palliative and supportive care at NCH. So let's get started. Please welcome Dr. Schwalm.
Well, thank you for that very kind introduction. Let me just put this down here. And so I'm going to spend about 20 minutes with you and try to cover 2 important topics. The first is bringing you up to speed on stroke, particularly the warning signs of stroke and what you can do to prevent a stroke. And I'm going to talk to you a little bit at the end about teleneurology and telestroke and how we're partnering together with Nantucket Cottage Hospital to improve the access to resources here on the island. So this is a picture actually of the Mass General Hospital. Here's the main entrance and here's sort of the side entrance. And I thought for this talk, we would just kind of properly title those so that the women's entrance for stroke is clearly listed. And for those of you who thought this was a golf lecture, I'm sorry, that's actually later this week at Merrill's house. So if that was why you came, it's okay if you leave now. So what we'll talk about today, we'll talk about what is a stroke and how stroke risk and outcomes might be different from women than they are from men. We'll talk about who's at risk for a stroke, and then how telemedicine has really changed the delivery of care, particularly in remote areas. So this is an actual fortune cookie that I got. It said, if the brain were so simple we could understand it, we would be so simple we couldn't. And I thought that always makes me think about Albert Einstein because he's so smart, I can't understand anything he wrote. So the very first description of stroke goes way back to Hippocrates, who's considered the father of medicine. He called it apoplexy, and that meant literally to be struck down. So people who had a stroke fell down to the ground, and in those days, stroke meant either a bleeding stroke in the brain or the blockage of an artery in the brain, either one. And it was sudden onset of paralysis. Doctors back then didn't even know the brain controlled the body. They actually thought that the humors that circulated in your heart and in your intestines controlled the body. It wasn't until the 1600s, when autopsy became an accepted practice and was no longer banned by the church, that they began to discover that patients who died of apoplexy often had either a rupture of an artery on the surface of the brain or had had a blockage of one of the major arteries. We know that today stroke affects about 800,000 patients a year. About 25% of those are in patients who've had a prior stroke. And about 7 million US stroke survivors are alive today. Unfortunately, the risk of stroke doubles every decade over the age of 45. So as we age and as we get better at treating lots of other diseases, the risk of stroke increases. So a lot of people ask me, are men's brains and women's brains different? And the reality is that for most people, most areas of the brain, except for some very subtle differences, the brains in men and women are very similar. The brain has many important areas that are demarcated to very specific regions. So motor control lives in a very narrow strip in the brain. Reading and language live in the temporal lobe near here in the back. Balance lives in the cerebellum. But how this affects our behavior sometimes is a little different between men and women. So I think many of you seem to be familiar here with some of these. I think the shopping lobe might be extra large here in Nantucket based on the downtown area. And I guess you have a Cisco brewery here, so the beer lobe might be a little enlarged too. So how does blood get to the brain? The blood comes through two major artery systems, the carotid arteries in the front of the brain, the vertebral arteries in the back of the brain. Here's a cartoon on one side. Here's an MRI scan that actually shows you flow of blood inside the brain. And really, at some level, it's plumbing. There are pipes that connect different parts of the brain. There are different connections that happen up here near the top of the brain so that if one artery is blocked, sometimes another artery can help out. And so a stroke occurs when an artery gets blocked by a blood clot. So here's a clot that started somewhere else, traveled up here, got stuck at this branch. This area here is the core of the infarct. It's irreversibly injured. It's going to die. But this blue part here is at risk. The brain in this area isn't working, but it's salvageable, and we call that the penumbra. Just like if you have a lawn sprinkler and it's not working properly, this part of the grass is dead. It's not coming back. This part of the grass is at risk. If you don't fix this, that grass is going to die. Same concept. And we can now image these different parts of the brain. Purple here depicting the core, green here depicting the penumbra. And we use these now to select patients for various treatments. So there are two major types of stroke. As I said before, blockages are caused what we call ischemic strokes, and a rupture of an artery causes a hemorrhagic stroke. About 85% of strokes are ischemic, and they are either from plaque in the artery, like in the neck, in the carotid artery, there's a big atherosclerotic plaque, or they're the result of very tiny penetrating arteries that supply the inner portions of the brain, or they are an embolism, a clot that came from the heart, often from a condition called atrial fibrillation. But about 30% of the time, we don't know the cause. And that means additional testing, unusual kinds of testing, and sometimes just time will tell as we understand when other risk factors emerge that we hadn't identified before. If you've ever heard of someone having an aneurysm or an aneurysm rupture, subarachnoid hemorrhage, that's what this looks like. That's when the vessel bursts inside the center of the brain along these channels where fluid is normally present, or in the substance of the brain, that's an intracerebral hemorrhage. The most common, and these again only make up 15%. So as I mentioned to you before, the risk of stroke doubles every decade over the age of 45. You can see that men have a higher risk of stroke than women, particularly in the 80-plus years, but women's risk is still doubling every decade. And this, again, as I said, is often due to the presence of something called atrial fibrillation, which increases as we get older. The good news is age-adjusted rates of death from cardiovascular disease and stroke have been decreasing for the last decade or two. They've plateaued recently, and we think that's because of the diabetes epidemic, the obesity epidemic, and so we may be seeing a little bit of a need to galvanize and make additional changes. But again, we've been making progress. So what about factors unique to women? So oral contraceptives. The question is, for a time we thought they were protective. Now we know they increase the risk, but very small. So the relative risk is large because it does double, say, the risk, but the actual absolute risk is so small that the proportional increase is small. So women in the Framingham Heart Study, which is a big community-based study, who had menopause before the age of 42 had twice the risk of stroke as women who had natural menopause after the age of 42. So naturally occurring estrogens make a difference. But giving estrogen to postmenopausal healthy women does not seem to protect against the risk of stroke in women who have established heart disease or a recent stroke or TIA. And in a British study, high-dose patches so greater than 50 micrograms of estrogen appeared to increase risk, but low-dose patches were safe. So the general consensus is low-dose estrogen doubles the risk of stroke, but the absolute increase in the risk is small. And if it's really needed for medical reasons or intolerable symptoms, we generally tolerate it. But in women who've already had a stroke, we really try to stay away from estrogens. What about pregnancy and stroke? Stroke is a rare but devastating event that can occur during pregnancy and happens in about 34 out of 100,000 pregnancies. 44% of them happen before the delivery, and about 50% after, and a very small portion happened during the delivery. And pregnant women who have strokes are younger than non-pregnant women. It's not surprising, and they have fewer risk factors, but they have similar short-term outcomes after stroke. And it suggests that there has been an increase in the proportion of pregnancies that were associated with stroke. Again, about 50% before and about 80% in the postpartum era. That may have to do with women having children with existing medical conditions or at older ages than they used to in the past. Preeclampsia, which is a disorder of pregnancy, can also increase the risk of stroke. How about migraine? So migraine with aura, which means neurological symptoms, is associated with ischemic stroke, particularly in younger women, if they smoke or use oral contraceptives. So another population where we really discourage the use of estrogen. And again, very rare in young women, but increases the risk about 9-fold compared to women who don't have migraine, oral contraceptive use, or smoking. So things you can do to reduce your risk. So it's interesting, after stroke, women seem to have greater disability than men. Women also are more likely to survive a stroke than men, so that probably contributes. And in about 6,000 women living in the community who were able to walk before they had their stroke, they were half as likely to be independent in their activities of daily living, grocery shopping, caring for their personal hygiene, making food, even after you control for differences between the women. And again, women have about a 50% lower chance of achieving independence 3 months after discharge. We don't fully understand why, but one possibility is that women are living longer. They're also more often living alone when they have their stroke, and so their ability to return home is limited by the fact there's no caregiver there. So what can you do to reduce your risk? Well, the first thing is work with your doctor. This says the ringing in your ears, I think I can help. So don't miss the obvious stuff. And the other is it's your ribs, I'm afraid they're delicious. So you got to think about what you eat, you got to exercise, you have to control your blood pressure, all the things you know about. So, this, by the way, says looking good, Frosty. So it's kind of hard to achieve that. It's pretty hard to stay that way. But modifiable risk factors, high blood pressure, this rhythm I called atrial fibrillation, carotid stenosis, narrowing of the carotid artery, diabetes, heart disease, a TIA or prior stroke, elevated cholesterol, hormone therapy, as I mentioned, and then the lifestyle factors of smoking, alcohol or stimulant use, physical inactivity, and obesity. The non-modifiable risk factors, age, gender, race or ethnicity, and heredity, we can't do anything about that, but they do increase the risk of stroke. What if we could magically control all the hypertension, all the cholesterol, all the smoking, all the fibrillation, and all the alcohol excess? We could reduce about 80% of all strokes. So that just shows you we're not doing a good job of controlling those risk factors. I won't ask for a show of hands, but I bet half of this audience is probably on either a cholesterol pill or a blood pressure pill or an aspirin or a stronger medicine a day. And the reality is that most of you are probably not hitting that target of where your doctor wants you to be. And we'll come back to that in a minute. So what is the blockage? So you can have a clot that breaks off from somewhere else and gets stuck, like I mentioned before, or you can have atherosclerosis. What happens is that you have cholesterol flying around in your blood vessel. It's very irritating. It starts to cause a little ulcer here underneath the surface of the artery, and the cholesterol builds up in there like a liquid. It's kind of like oatmeal texture. And if that cap ruptures and this cholesterol exposes itself to the bloodstream, a clot forms immediately and can either block the vessel or travel upstream. If you get on your statin and you exercise and you do all the right things, this turns into a fibrous cap, and the cholesterol basically disappears and is replaced by scar. And then you get narrowing of the artery, but you don't have the clot that forms. And by the way, this is an actual specimen of a carotid artery. Isn't that really horrible looking? That was on the inside. So all this stuff yellow is fat underneath the blood vessel, and here's the ruptured plaque with the blood clot sitting on it. You don't want that. Not a good thing. But atherosclerosis is a systemic disease. It affects all the arteries in the body, and I've often made the comment that I think we really need something more like Atherosclerotics Anonymous. It's like everybody, heart disease, peripheral artery disease, stroke, we should all be in one room together learning how to get healthier together. So let's just talk for a minute about the first breakthrough drug we had in stroke prevention was aspirin. It's been around for a very long time. It was actually discovered by a chemist at the Bayer company, which is a dye manufacturer in Germany. They dyed carpets and other things. It was a chemical factory. And they purified aspirin. That was in 1897. The next big breakthrough came in the 1950s when the Wisconsin Alumni Research Foundation, which was a group of people who went to University of Wisconsin, funded through philanthropy, research projects. And they said, we need help with rat control. There's too many rats in the granaries. They go and they ruin the food. We want to save it during the winter so we can have stuff to eat. So they said, well, okay, we'll make up poison that the rats will eat it and they'll go back home to the woods and then they'll hemorrhage internally and die. And somebody pretty smart in 1949 said, hey, why don't we use that on people? But in a good way. So that's warfarin, that's Coumadin, that's the medicine that thins your blood to prevent you from having strokes if you have a condition like atrial fibrillation or if you have a problem of excess blood clotting. So how to avoid a stroke? Well, the first thing is avoid magical thinking. What if we don't change at all and something magical just happens? I would say that should be in the waiting room where I work. So know your risk factors and goals for each and manage them with your doctor. And particularly focus on the target, not the dose. It doesn't matter what the dose is, it matters if you get to the target. Get the blood pressure down below 120/80. Yes, 120/80. The data clearly shows that's, if you can tolerate it, that's best. Get your blood sugar in the normal range. Lower your bad cholesterol, your LDL cholesterol below 100 or even below 70 if you can tolerate it. Take your medicines as prescribed. Treat an irregular heart rhythm called fibrillation if you have it. And by the way, in the setting of atrial fibrillation, women are more likely to have a stroke than men are. So if you have fibrillation in this audience, make sure you're being treated appropriately. And if you have a narrowed carotid artery and it's been causing symptoms, you want to get that treated. And again, healthy lifestyle, less than 1 drink per day, don't smoke, exercise daily, eat a healthy diet, and aim for a waist circumference if you're a woman. Tape measure around the waist, not the pants size, not down by the knees, right here, across the tummy, less than 35 inches. All right, you all know the importance of research and philanthropy. Here's those of you who are fans of the movies, yes, Young Frankenstein, but the great discoveries come when we have ideas stimulated by support that allow us to do innovative, cutting-edge research that's not yet ready for primetime funding from organizations like the NIH. And this thing over here, by the way, is a fancy new catheter that pulls clots out of arteries, and I'll show you that in a few minutes. So does anyone in this audience know how the Beatles actually changed acute stroke care? Oh, good. Because I talk about this a lot, and usually there's 1 or 2 people who go, I heard you say that last year. So 1950s, the Cadillac Meteor was a repurposed hearse, actually. It became the first commercial ambulance. And in the 1960s, the Beatles were signed by a group called EMI, Electric and Musical Industries, which basically they made recording instruments. They made magnetic tape, they made records, and they didn't really understand much about music. But the Beatles made them so much money, they didn't know what to do with it, so they turned to their engineers and they said, here, anyone have any good ideas? We'll fund some good ideas. And this guy Hounsfield said, well, what if I made a machine that could measure the density of things? And they said, okay, and that was the CAT scan. And with the CAT scan came the possibility of acute stroke treatment. So what do you do if you think you're having a stroke, and what are the signs of stroke? The most common recognized warning signs is the FAST campaign. It's face, is the face crooked? Arm, is the arm drift? Speech, is there a problem with speaking or understanding? And if any of those are present, T is for time, don't waste time, call 911. Because every minute that a stroke goes untreated, 2 million nerve cells die, 14 billion connections between them die, 7.5 miles of fibers connecting them die, and your brain ages about 3.5 years every hour you go untreated. So early treatment is critical. So this is I kind of added this here. Hopefully that's not what the weather's going to be tonight when we take the ferry back. So normally we have these things called acute stroke ready hospitals, and that's would be what the hospital here would be considered. They have basic services, but they can't provide inpatient care with a stroke unit and speech therapy, physical therapy, rehabilitation. Primary stroke centers can do all that, but they can't put in the catheters, take out the large clots, and take for the most severe strokes. That's where the comprehensive stroke centers come in. And you, through telemedicine and the helicopter, essentially have access to a comprehensive stroke center. The chain of stroke survival is only as strong as its weakest link, especially with these more severe strokes. So we need good and early recognition and activation of EMS. We need to be able to screen patients in the field to make sure we identify the patients with this who are at risk for the very severest strokes. We need thrombectomy, which is removal of the clot done by an expert operator, and that happens at high volume centers. Then we need stroke unit care or neurocritical care if needed, and starting off secondary prevention. And then finally, we need early rehabilitation to maximize recovery. So this is called mechanical thrombectomy. This is my first case that I was involved with back in 2004. Here's an artery, like I showed you before, it's blocked here. It should be filling out like this. Here's a catheter that's been advanced through an artery in the leg, up here into the brain, and there you can see the catheter is being deployed, where the green arrow, by the way, is not in the brain. That would hurt. That's just on the slide. And then the catheter is removed and the clot comes with it. And here's what those clots look like when you take them out. And this, by the way, this little segment here is only about 5 millimeters in diameter. So a really tiny clot, smaller than the tip of a pencil, can cause a major stroke. So we are actually pioneers in the field of teleneurology and telestroke. That's actually me. I think you see me leaning out of the screen there to look at George Jetson. He's actually at the Nantucket Cottage. It's a new hospital, by the way. If you haven't seen it yet, it's very, very fancy. So teleneurology involves basically what looks like a little workstation on wheels with a camera and then a screen that lets you see the doctor on the other end. And the doctor is examining the patient at the bedside. If we determine a stroke is present and it's early in the course of the stroke, we may recommend this medicine TPA, which is a clot-dissolving medicine. When you inject that in the bloodstream, it actually dissolves the clot that's blocking this channel and restores blood flow, if you're lucky. These are some of the really amazing and nationally and internationally recognized stroke neurologists who you might see on the other end of the line if you're unfortunate enough to be in the Cottage Hospital and having a stroke or something that they think might be a stroke. And this is just a summary of what our teleneurology program has brought to the community. So we're in about 30 hospitals in New England. We cover 6.5 million New England residents now can go into an emergency room and be connected with a Mass General neurologist. We've done over 1,800 consults for stroke. We call that telestroke. And 36% of the time we treat a patient with TPA compared to 6 to 10% as the national rate when you just walk into an emergency room. We've done over 2,000 teleneurology consults, for other problems, not just stroke, and have reduced length of stay in those hospitals by about 33%, saving about 2,000 days of beds in the hospital, which Margot will know is a terrific thing because then more people can get in and actually get into a bed because getting a bed in a hospital can be very challenging. We've done over 800 virtual visits with our own patients who live in and around Boston and the surrounding area. Instead of coming back into the office in person, they can be seen over video, like Skype, but medically secure. We've also started doing remote interpretations of EEGs, a brainwave measure, doing neurocritical care consultation. And because we can keep 88% of all patients in the community hospital after the referral is over, we've also brought about $11 million of additional revenue back to those hospitals because they get to keep those patients, keeps those hospitals solvent. So it's very, very important. So since 2018, we've had 28 patients on the island here who've had a telestroke consult. Over 50% of those, not surprisingly, occur during the summer months, but 50% occurred not during the summer months. We only had one patient who was eligible for TPA, and they were treated and flown to us to undergo this clot retrieval thing. And 16 of those 28 were able to stay here and either finish their vacation or keep living here. 9 were transferred to us, and 3 at the end of the consult, we still hadn't determined where they were going to go. So again, very effective at keeping people here. And then we have a teleneurology program where we have 2 neurologists who travel here on a monthly basis with weather and season permitting, and then do follow-up visits over video like I manage, and have really been able to enhance access to neurology services on the island. We did 47 virtual visits and 71 in-person visits. So again, over 100 visits with the neurologist that otherwise would have required the trip that we'll be making later tonight to get back to Mass General, which is not a fun trip, especially if you have a neurological problem that you want evaluated. So this is what it looks like. These are our clinic patients. We now see patients from the office in a variety of locations on an iPad, on a tablet, sometimes even now on a smartphone. And I think the reality is that the 21st century doctor's bag is going to look different than it did in previous generations, and technology is increasingly going to be a fundamental part of that. And it really provides an incredibly meaningful conduit between residents and visitors to the island having access to tertiary care. So thank you very much for your attention.
Hi, I'm Dr. Frabel. I'm the medical director of the emergency department at Nantucket Cottage Hospital. And just wanted to share with you a brief story about how telestroke really works in the emergency department. And I can tell you it is absolutely amazing. Oftentimes we need a specialist in the emergency department, and we have the clerk call Mass General, call the paging service, could you please find this doctor? They page the doctor, half an hour goes by, would you please page that doctor again? Another 15 minutes goes by, this isn't working. But when somebody comes in with a stroke, you call telestroke, you call the telestroke fellow, and poof, there's a neurologist in your emergency department. And it's like a miracle. And they're on the screen, they're talking to the patient, they're talking to me, they're talking to the patient's family, and they're counseling regarding medications that we can try and expected outcomes and prognosis, things that go into a great deal of expertise that we don't have in the emergency department. So recently we did have a patient who came in with a severe stroke, and I was on. Actually, I was called in to assist, and the first thing I did was call telestroke, and then the stroke fellow is who's on call. Basically held my hand the entire way, and said, well, call me back when the patient comes back from the CAT scan. Well, she didn't wait for the patient to come back from CAT scan. She called me and said, is the patient back yet? And advised every step of the way. So it is a fantastic program, and I'm very grateful that we have it in our emergency department. Thank you very much.
So much. I'm Vicki Jackson, and I'm delighted to be here with you tonight. I'm going to talk to you a little bit about the work that I do as a palliative care physician in Boston at Mass General, and I also co-direct the HMS Center for Palliative Care. And we're going to talk tonight about what do we know is important for patients living with serious illness? What actually is this thing called palliative care? What is the evidence for this new specialty? And I always say, what's in the palliative care syringe? What are we actually doing when we're in a room, exam room, with a patient and their family? We'll talk a little bit about what we're doing at MGH to help improve the experience for those with serious illness. And then really think about, for you personally, how can you think about your goals and values? I've done several presentations for women in this sort of space. And I think, although I don't know that I totally agree with those like two things with the shopping thing or whatever, I do know that one thing is true, which is that women often are caretakers in a whole variety of ways, as a daughter, as a mother, as a spouse. And it's people come to us for these conversations and to help navigate really difficult times. And so palliative care is a really important tool and partner for you when you're in a place where you're needing to help people who you love and care about when they're living with a serious illness. So that's what we'll talk about as well. So, I really feel like there's this cultural shift that's underway. And I don't know if you've noticed this, but I feel like you can't pick up the New York Times or the Washington Post or the Wall Street Journal without some article about thinking about how patients are living and dying, and are we meeting their needs? What we know is that actually we haven't historically done a great job thinking about how to take good care of patients with serious illness. Sometimes we've been really focused on only a cure, but without actually seeing, is this cure helping, this quest for cure, helping the patient and family live as well as they can? So what do we know that patients with serious illness want? They want relief from symptoms. They don't want to be in pain or have shortness of breath. They don't want to be a burden to their family. They want to achieve a sense of control, often in the setting of an illness that has robbed them of any sense of control. They want assistance strengthening relationships with people who they love, and they want informed, shared medical decision-making with the medical care team. And, so what patients will say to me is, hey, Vicki, if you think I'm living, like, help me live, help me do that, help me do the things I want to do. But if you actually think I'm dying, don't make that dying part longer, right? So part of the tricky thing for us in medicine is to understand where are we in the course of this illness and how do we help a patient and family actually achieve what goals and values are important to them. To sort of make this point, I'm going to introduce you to a patient named David. Was a gentleman who was admitted to MGH. He had metastatic renal cell cancer, was admitted with severe pain, and we had to do all kinds of very complicated procedures and medications to try to get his pain under good control. And this was an interview that I did with him. And what I want you to do, I'm going to sort of poll the audience a little bit. What do you think is important to David? What do you hear him say? And what do we know that is my job now that we've heard what's important to him? Your sense from Dr. Lee is that the cancer is growing in your belly.
Oh, absolutely.
And he's pretty worried about that. Is that your sense?
Yeah,
Yeah.
that's about it.
Yeah. And so it sounds like when I hear you talk about it, David, that you have a sense that time's not unlimited, that at some point this cancer may take your life.
Oh, yeah, absolutely.
That's your sense?
Yeah,
Yeah.
it's gonna,
Yeah.
sooner or later.
Yeah.
Yeah, it's growing, it grows fast,
Yeah.
and it's not afraid.
The cancer's not afraid?
It's not afraid.
It does its thing.
It wants to eat more of me.
Yeah. And how do you make sense of that day to day? How do you live with knowing that time's shorter than what you'd hope?
Well, I really can't change the fact that it's gonna get me. That I can't change. It's accepted. What I can change is the amount of time I have to use it wisely and understand it, that I am gonna, if I have 3 months left, I want to do as much as I can in that 3 months. And I got to learn what it is that's left. In other words, I want to spend time with my wife, make her something that shows how much I love her.
Yeah. What do you want to make her?
It'll be something out of wood, of course. I don't know yet. It'll come to me.
The spirit will move you.
Yeah, that's right. Maybe something she can hang on the wall, maybe. A piece of art. I don't know.
So what did you hear is important to David? I wish you could see him. He's got a great T-shirt on that says "Cancer Sucks," which I just love. I completely love. What did you hear is important to him? Life. In what way? And doing what part of life? Doing what? Spending time with his family? Yep. What else? Leaving a legacy. Say more. What does that mean? What does a legacy look like for David, do you think? Creating something. Yeah, absolutely. So what did I learn in that encounter that tells me what my job is for David? What do I need to do? Say again? Prioritize time. What else? I got to keep him out of the hospital. I got to get his pain in control so this guy can get in his wood shop, right? That's my job, right? And it is also that I help him. For him, having more chemotherapy felt really important. So it was me helping him be able to get the chemotherapy and do the treatment that was important, and also be able to achieve those goals that were important to him, right? So that's what palliative care is, right? Why you guys are so incredibly lucky that you've got supportive care and palliative care on Nantucket and have had such an amazing community support. I've been doing this for 20 years, and the community support you provide to palliative care here is renowned, right? Just so you know that. So you should be very proud of that. But this is what it provides. It allows a space for patients and families to talk about what's important to them versus this was a patient of a colleague of mine when she was at UCSF. It was a gentleman who had obstructive pulmonary disease, and he had been intubated in the hospital over and over again. And she went to see him to ask him that question, what's important? And he had a tube in his throat, so he couldn't speak. And he grabbed the piece of paper away from her and he wrote, "Let me go." Now, that's when we have failed. We have failed if we don't ask these questions until patients literally have lost their voice. Right? It's always feels too early to talk about these important things until it's too late, right? So that's what palliative care is. Palliative care is help for patients with serious illness. I trained in internal medicine and then did extra training at the Dana-Farber and the Brigham in palliative care. Palliative care is appropriate for any age, any diagnosis at any stage, and is provided at the same time patients are getting disease-modifying treatment. My job is to improve quality of life. So when I walk into a patient's room, I say to them, my job is to help you live as well as you can for as long as you can in the face of this illness. And what's really terrific for me is I get to work with an interdisciplinary team. I get to work with nurses and nurse practitioners and chaplains and social workers to be able to help provide all of the care that patients and families need. Now, I will say palliative care is still confusing for people. So sometimes they'll say, and this will happen with doctors too, they'll say, well, they're not ready for palliative care, Vicki. We're not giving up. I'm like, yeah, me either, as it turns out, right? Like, I'm helping David get into his wood shop. Like, I got lots of things to do, having his pain in good control. So what palliative care is evidence-based, excellent medical treatment, vigorous care of pain and symptoms throughout the illness, and care that's happening at the same time patients are receiving curative or life-prolonging treatment. And the key thing to know is that it's different from hospice, which is really pretty confusing for folks. So how does it differ from hospice? So hospice is actually a medical insurance benefit that provides care for patients often in the last weeks to few months of life. Technically, to be eligible for this insurance benefit, patients have to have 2 physicians certify that they have a prognosis, a life expectancy of less than 6 months. Now, I would say I'm a big fan of hospice. I think it is the gold standard of end-of-life care. The thing that is tricky about it, however, is that in most situations, patients have to forego treatment like chemotherapy, radiation, not all the time, but often in hospice because the finances just don't work out. Medicare doesn't pay the hospice enough money to be able to offer those treatments. The thing that's terrific about palliative care is we can do both. We can provide the symptom management, extra layer of support to the patient and family. At the same time, they're getting a bone marrow transplant or getting a heart transplant. So what is the evidence for this palliative care? I'm going to talk to you a little bit about the work that we've done at MGH. This is a terrific collaboration I've had for about 15 years with a dear friend and colleague, Jennifer Temmel, who's a lung cancer doctor at MGH. We took 2 groups of patients and we randomized them. They had metastatic lung cancer, advanced lung cancer, and we randomized them to see palliative care from the time of diagnosis and then monthly until the end of their life, or whenever the oncologist decided to refer. And we looked at their quality of life, their mood, and also how much they were in the hospital and how much they understood about their illness. And there were several important findings. One was that patients who saw palliative care had an improved quality of life. I always say that was lucky because that's my job. Would have been super embarrassing, right? Super embarrassing. The thing that I'm probably most proud of is the fact that there was a much lower rate of depression in patients who saw palliative care early. Now, mind you, both of these, we've now done 3 other studies which have shown the exact same things in different patient populations. So patients who saw palliative care early were less likely to be depressed. And what was really interesting, I remember in this first study, a patient said to me, Vicki, let me get this straight. You're going to help me do the stuff I want to do. And then if I should worry about the illness, you're going to tell me. Otherwise, I should just do my thing. I'm like, that sounds awesome. So really, there is this way that being able to talk about these things and prioritize what's important actually has a really important effect on mood. What we also did is look back to see whether we prescribed more antidepressants. We didn't. So this is really about this sort of form of care and support for patients and families. We also found from our work that patients were more likely to understand what was likely going to happen with their illness. What we know from multiple studies is that patients, when they're first diagnosed with a serious illness like cancer, maybe understand about and integrate about 30% of what the clinician says, which makes a ton of sense, right? Like a bomb blew up in your life, and it's just too hard to integrate all of it and make sense of it. When patients see palliative care, they're more likely to have an accurate understanding. We also found that patients who saw palliative care early had different healthcare utilization. They were more likely to receive hospice care and for a longer period of time. They also were less likely to get intravenous chemotherapy in the very end of life when it's less likely to be helpful. Now, the result that was really the reason this got a whole bunch of press and got into this very prestigious journal, the New England Journal of Medicine, was because the patients who saw palliative care early lived nearly 3 months longer than patients who didn't. That's the same survival benefit you saw from first-line chemotherapy at that time. And why did we look at survival? Did we look at survival because we thought that I was going to be like the next newest drug, like chemotherapy drug? No, it wasn't that. It was because we knew that if patients didn't live as long and they saw palliative care, that was going to be a big critique. People would say, sure, Vicki, you made them feel better, but they gave up and died sooner. That is absolutely not true. Our research has shown that, multiple other studies has shown that there is no difference in survival and potentially a prolonged survival when patients actually have their symptoms well managed and their mood is well managed and they're coping as best as they can. So whenever I give talks anywhere, they always say to me, well, Vicki, what's in the syringe? What do you actually do? So we're spending a lot of time looking to understand from our data, from the multiple studies we've done, about why is it that we see these important benefits. And one piece that we have really come to understand that's important is this concept of prognostic awareness. And the way I define that is a dynamic understanding of what's likely going to help or going to happen with the disease trajectory. And why is it important to have some sense about what the future holds? One is that we know patients can better weigh burdens and benefits of treatment. They can have more meaningful discussions about their goals and values, about what's important, like David's sense of getting out in that wood shop. And they can match medical treatments to their goals and values. You know, and we've started to think about this sort of watching how patients cope with their illness, sort of like a swinging pendulum. And you may have noticed this in yourself if you're sick or someone you love, is there are times when you feel super hopeful and like it's gotta be wrong. It can't be right that this is happening. And that's really adaptive and normative. And that there are times when you have a sense that something doesn't feel quite right, and that you're not sure what the future holds. And to be able to have a way that you can be hopeful and really live life fully and begin to slowly acknowledge if this disease gets worse, that's really important. That's really important for patients and families to be able to do the good work that they need to do. So we sort of use this schematic to think about why it's important that patients have a deeper awareness about what to expect. And that's because we know that people have different goals and values. If I have a sense that time could be as short as 6 months or a year, I'm going to have very different goals and values, and I would go through different things than if I knew I had 6 or 10 years to live. Right? If I thought the treatment had a high likelihood of cure, I might be willing to go through the most difficult, strenuous thing for this chance of cure. But these are all really important discussions that aren't one discussion. They're several. Sometimes they're 10 or 15 or 20 discussions that patients and families have together and with their care team. And what we notice is that as patients have this different sort of prognostic awareness, they make different medical decisions. Maybe more likely to say, yes, this treatment is really important, but I don't want to spend a month in the hospital for it. That feels like too high of a cost. And part of the way I think about it is if we don't talk to patients about this, they don't get to tell us what's important and be empowered to make the decision that's right for them. Right? It's about what decision is right for them. So the way I think about this is part of what I'm helping patients do who have serious illness. illness that may be something that could take their life, is to help them do both. Live well and figure out what that looks like. I am forever like planning trips, helping people plan trips and like MacGyvering how they get on the plane with the oxygen and whatever. See, not everybody knows MacGyver, but thank you. And also to hold, if in fact this dying is something that could happen, what do we do with that and how do we think about it? And that really informs patients' goals and values. I had a patient who I was caring for several years ago. He was a man in his 40s, a venture capital guy, and he was used to like, you know, kind of being in control of stuff, right? He would say A and like B would happen. Like that's just how life went. And for him, it was really hard for him to make sense that he could really die from this tumor in his pancreas. And he was getting very aggressive treatment with us at MGH. And then he was going to place. He was going to Memorial Sloan Kettering and MD Anderson because he just couldn't believe that this couldn't be cured and taken away. And one day I'd been caring for him for probably 8 or 9 months. And he said, "Can I ask you a question, Vicki?" I said, "Sure." And he said, "Do you really think I could die from this? Like, seriously?" And I said, "You know, given what we know right now and the medical treatments we have, my worry is this is going to take your life." And he had 2 young children. And he said to me, "Vicki, why have you been letting me go all over the country? I should be home with my children." And I was like, right. A deeper awareness means different goals and values, and people make different medical decisions. That didn't mean that he didn't have incredibly aggressive treatment with us, every possible clinical trial that could be offered to him, but he wasn't willing to go all over the country and not be with his family. That was too much of a cost, right? But unless we can have a dialogue about it, we can't match treatment decisions to patients' goals and values. So let's talk a little bit about what we're doing at MGH to help improve the patient experience for those with serious illness. So part of the thing that's really tricky about serious illness is that it's not always clear where you are, right? So these are 3 different graphs depicting sort of illness trajectory for different patient groups. The dark one at the top is sort of cancer. So patients do really, really well often until the disease doesn't respond to the treatment anymore. Patients with organ failure, like heart failure or kidney failure, often have ups and downs. So they will start out doing okay, then they'll have a decline in function, and then they'll improve, but they will never get to the function they were before. And it's really confusing because if we see somebody when they're at the bottom of that red line, it feels like, oh, I think time could be short. If we catch them when they're at the top of the plateau, we think, hey, we don't know how things are going to go. So having these conversations can be really difficult to think about timing because often people will say, well, don't have me talk about it now, that's too hard. And I don't want to talk about it yet. But the concern becomes if we don't know what's important and we wait too long, patients' voices may not be part of this conversation. And what we know, unfortunately, is that conversations are often infrequent, they're late, and they often fail to address quality of life issues and what's important to each of us. So part of what's important, and I would say that I would love for each of you here to be able to go back to your communities and to talk about, let's have a conversation about what's important to us, right? So we actually know, so we can sort of break the ice in this conversation. So many advanced care planning documents are kind of confusing. So I'm just going to go through them quickly just so everyone can kind of understand these different pieces. So advanced directives are documents that outline your wishes about treatment. There's a living will that's completed with your attorney. What's really interesting that most people don't know is whatever you do with your attorney doesn't translate into what Lee and I do at all. Okay, it's not a medical order. So you might have had all this discussion, but if you don't tell your doctor, it's not going to be translated into the care that you want. A 5 wishes form is a form that goes over helping you think through what might be important to you at the very end of your life. That's completed independently. And a MOLST form is a medical order for life-sustaining treatment, and that is what's called here in Massachusetts, and that's a form that you need to fill out if you want to complete that with your physician. Other really important things are to think about having healthcare proxies, an agent of your healthcare proxy. And that is, if I am in a car accident and I can't make decisions for myself, I know my husband is going to help make decisions for me, and a dear friend of mine who I think knows me well and could be my voice if my voice weren't able to make those decisions. And also, in some places, it's called a durable power of attorney for healthcare. In Massachusetts, it's a healthcare proxy. So, but the thing that's really important is you can assign somebody to make decisions for you, but if you don't talk to them about what's important, it's really, really hard. And for any of you who've had older parent or sibling who you've had to care for, if you haven't had the conversation, it's really tricky. I remember when my sister and I were healthcare proxies for my mom, we tried to have this conversation and she said, I cannot believe I raised 2 daughters who are so mean to make me talk about this stuff, right? So just because you're a doctor, my sister's a nurse, doesn't mean these conversations are easy, but it actually made it much harder on us because we had to guess what she would have wanted. So you can give a great gift to your family by telling them what's important. So we're doing this program at MGH called the Serious Illness Care Program, where we're actually training clinicians to have these serious illness conversations with patients way before you need it, years ahead of time, to begin this conversation. So some of the questions we may ask are, what is your understanding of your illness? Looking to the future, what are your hopes about your health? What are your worries? So we can begin to understand how you want to live your life with this illness. So at MGH, since 2017, we've trained over 1,000 clinicians and changed our EPIC to be able to document these conversations. Because if an oncologist has a beautiful conversation, or a primary care doctor, if our emergency clinicians can't see that when you come into the emergency department, it's not very helpful. So this is a way to actually make it much better for the clinicians to be able to understand what conversations have been had and that we can all share in that work. So just as we're wrapping up here, I think it's important for you to think about what you can do to advocate for yourself and also your loved ones. So if you haven't assigned a healthcare proxy, make sure and do that. And think, who do you think would be able to make good decisions for you if you weren't able to speak for yourself? I will say that I have many patients who actually don't choose their spouse, which is interesting because they worry that their spouse might not be able to make the right decisions. They choose a sibling or a good friend. It doesn't really matter who it is, as long as it's someone who would know what was important to you and be able to be your voice and who you feel comfortable having a conversation with. I think it's important to do some personal work. What's important to you now? If you were sick with a serious illness, what would be important to you? And what does quality of life look like for you, right? So someone I knew said quality of life was if he could watch football and eat chocolate ice cream. Okay, I got a little different thing that would be important for me, but if that's it, that's important for the people making decisions to know, right? And so what does quality of life mean? Does it mean trying every possible treatment? Does it mean spending as much time at home as possible? Does it mean trying to do both? And making sure that whatever those goals and values are that are unique to you, that you share those with the people who can actually be helpful to you at this time. So thank you so very much.
Well, wow, Vicki made it very easy for me. She explained all the hard stuff. And now I can just focus on an organization that is very near and dear to my heart. I'm Diane Bean, as you were told earlier, and I'm very happy to be here to tell you about the palliative services that we have right here on this little island of Nantucket. I'm the program director of Nantucket's not-for-profit palliative foundation called Palliative and Supportive Care of Nantucket, or PASCON for short. You've probably heard about us. I'm also the clinical manager of the palliative department at Nantucket Cottage Hospital. This is a little unusual. My dual appointment is in an unconventional relationship to the hospital, which is like many things on Nantucket. It has emerged from the unique challenges and opportunities that come from living 30 miles at sea. Although PASCON is privately funded by the generous support of donors in this community, The Nantucket Cottage Hospital provides our office meeting space and a roof over our heads, for which we're very grateful, and a part-time social worker, which we use a lot. My team and I get to wear 2 hats and spend time with the amazing hospital oncology team. We visit our patients on the med-surg floor, or we show up with Faith Frabel, who was here earlier, excuse me, in the ED, in the emergency department. In turn, we provide completely, now get this, free palliative services to the hospital's patients, along with support for their families and their caregivers. There is no billing in our department, nor are there financial restrictions or limitations. Doesn't matter how much money you have or don't have. Our relationship to the hospital is a beautiful marriage where we work together for the good of this beautiful island. When I'm asked what PASCON does, I have the same sort of mantra that Vicki has. I sum it up by saying we help people live better and often longer with life-threatening illness. We do whatever it takes to support patients and those we depend on and those they depend on, with a focus on helping patients to better manage their symptoms and their radically changed lives. We see patients wherever they are in the community, and we take a holistic, integrative approach because all of us are more than physical beings. We all have psychological, spiritual, and social needs that impact our physical health. PASCON has been taking care of patients and their families on Nantucket for more than 30 years. We were sort of ahead of the curve on this. We've only been able to do so through the generosity of donors, 17 current volunteers, and a wonderful working, sleeves rolled up kind of a board of directors. Our small staff are certified specialists in palliative medicine, cancer care, bereavement counseling, and hospice care. While we spend a lot of our time and energy managing pain and other symptoms through conventional medicine, we also support and implement integrative therapies such as Reiki, yoga, and meditation. What else do we do? We'll try to imagine staff, volunteers, and our board members, because we're all a team in these scenarios, driving a patient to his many weekly chemotherapy treatments in a big red pickup truck, which he's crazy about, by the way. Attending MGH specialist appointments with our patients for extra support, and as Vicki said, extra ears because they don't often hear what is said in those meetings, those appointments. So we help support them and sometimes remind them of that. Reading poetry to a 97-year-old bedbound literature lover, or staying with a dementia patient while her husband gets a haircut or mows the lawn. Sharing the lives of a heroic group of cancer patients who often endure numerous clinical trials hoping for a cure or at least remission of their disease. We laugh more than any group I've ever attended. Serving on a call list to support emergency room staff here on Nantucket when a spouse is instantly left behind after a horrific accident. This happens on Nantucket in tragic bicycle and moped accidents, and I've been part of that. Assisting a volunteer chaplain to conduct bedside rituals to a dying patient in the emergency department. I've also done that recently. Managing a palliative cart stocked with snacks, coffee, reading materials, and calming music for families holding end-of-life vigils on the med-surg floor. Our volunteers do that. Working with VNA Cape Cod hospice nurses, because remember, palliative is not hospice. We know how to do hospice, but we're not hospice. And we support them in their care so that these patients on Nantucket can have Medicare-certified hospice care, and we support their care with these end-of-life patients here. And offering any cancer patient transportation and lodging funds for off-island treatment through the Marla Seeley Lamb Fund here on island. These patients have one less thing to worry about. I could go on, but you get the idea. There is no limit to the feel good by doing good opportunities in this organization. As I look around this room at the demographics, The ages are all over the place, thankfully. But there's one thing that's mostly in common. We're mostly women. And that translates to mostly caregivers. My hope is that none of you ever need our services personally for your own life-limiting diagnoses or those of your loved ones. The odds that you at least be touched as a caregiver to a good friend or a family member, perhaps an elderly parent, or God forgive a child, who must deal with a life-threatening illness like cancer, MS, Alzheimer's, ALS, or heart failure. Should you find yourself in such a situation, please remember that PASCON is here for you. With continued support from generous donors, volunteers, community grants, and our board members, PASCON will continue to be here for all of us on Nantucket. Thank you for your time, and I will be glad to entertain any questions or talk with any of you later on. Thank you for having me.
Well, hello everybody. I'm Mary Tate, and we have 5 minutes for questions and answers for Dr. Schwalm and Dr. Jackson. Please raise your hand high because it's hard for me to see with the lights here.
Is there any PASCON in any other cities in the United States?
PASCON is right here on Nantucket. It was developed 32 years ago here on the island with a collaborative effort with the hospital. So we are very unique and don't know of any other place. I don't think I'm going out on a limb to say that palliative services is free anywhere else.
Back there in the...
I don't like microphones. Hi, Dr. Schwalm. There's a lot of controversy about women taking baby aspirin. What's your feeling about that?
So when we talk about stroke prevention, it's really important to distinguish what we call primary prevention, people who've never had a stroke, versus secondary prevention, people who've already had one stroke and are hoping to prevent another. And so the information you've seen in the news lately had to do with something from the Nurses' Health Study, which were healthy women who took a baby aspirin a day for decades in the hopes of preventing heart disease, stroke, and other complications. And what the data there suggested, if you're healthy and you have no risk factors, the benefits of aspirin were balanced by the increased risk of bleeding, mostly bleeding in the gastrointestinal tract. But unfortunately, that message has been maybe not accurately characterized in the media, and now I'm getting lots of questions from my patients, do I still need to take my aspirin? So the answer is, if you have established risk factors like heart disease or atherosclerosis anywhere in the body, an aspirin a day is vital. But for people who are otherwise very healthy and do all those things that I said that you were supposed to do, an aspirin a day may not keep the doctor away. It may actually have you visiting Dr. Hartman's emergency department.
Is there another question?
Dr. AFib, more and more of my friends are being diagnosed with AFib, and I as well. And so what my concern is I'm looking at the statistics. I have greater women with AFib have a greater chance of having stroke. And you gave us some of the risk factors and what we should do. We really can only have less than 1 drink a day.
So I'll repeat that for those in the back who didn't hear the distress generated by the risk concern of 1 drink per day. So there's a couple of, that's a great question, and everybody's listening and leaning forward. I did say 1 drink per day on average. Prior to about 4 or 5 years ago, the only medicine we had that was effective in reducing the risk of stroke in people with atrial fibrillation was Coumadin. Coumadin is unfortunately a drug that has many interactions with medications, foods, and alcohol. So if you're on Coumadin, alcohol is a bad idea, because the liver digests alcohol and the liver also digests Coumadin. And if you were to have actually like 1 or 2 drinks a day every single day forever, it would probably be okay. But fluctuations in alcohol with Coumadin cause the drug levels of the Coumadin to go up and down and up and down. That's not a good thing. The reason we now have newer medicines, Eliquis or apixaban, you may have heard about. There's a lot of advertising on Pradaxa on direct to consumers. Those drugs don't interact with alcohol, in a negative way. So in that regard, you're looking happy now. In that regard, they're probably safer when combined with alcohol. However, the most important contribution to stroke risk is high blood pressure. And when people drink alcohol on a regular basis, it increases their blood pressure over the years. All of us, as we age, have an increased tendency for high blood pressure. Alcohol worsens that tendency. So I think, as Vicki would say, what are your goals and values? And Pinot Noir or, Sauvignon Blanc. But I think moderation is really what's, the key message, right? And so the key is to avoid excess alcohol consumption and particularly binging. So, lots of alcohol in one single night, not a good idea to mix with the medicines we use to prevent stroke.
Okay, we have time for one more question.
I take Eliquis. I'm not going to ask you that during game. But
Marijuana's okay. No, just kidding.
I recently had surgery, and I had to stop the Eliquis for a few days. That was very disconcerting. I had different answers from doctors, and now I have another. I'm starting chemo shortly. I'm concerned. What are could Eliquis be involved in anything with chemo?
Yeah, so just so people could hear the question, it was when you're on a blood thinner and you have to have a surgery, it often has to be interrupted. The good news, again, is that the older medicines like Coumadin had a very long half-life, which means if you took a pill on Monday, you'd still have the effects Tuesday, Wednesday, into Thursday, which means if you were going to come off the pill, you were talking a couple of weeks before they were sure it was completely out of your system and safe to do surgery. With the short-acting drugs like Eliquis or Apixaban is its generic name, they last for just over 12 hours, which is great because you can stop it a day or two before surgery. It's totally out of your system. They can operate, and they can start it up again a day or two after surgery. And the risk that you experience in that period of time without the drug is very small and is very, very safe. The downside is if you don't remember to take your pills regularly, you skip a day or two, you're totally unprotected. So in the medical community, we kind of go back and forth on whether it's a blessing or a curse because it allows us to do lots of things we couldn't do before. But boy, if you don't take your medicine regularly, it's a problem. I have a patient of mine recently, and I asked him if he took his medicine. He said, like a religion, doctor. I said, how often do you go to church? He said, well, maybe once a week. I said, I want you taking your pills more often than that. So thank you for your question, and good luck with your chemotherapy.
And thank you for the questions and answers. Thank you very much.
Thanks to everyone for being here this evening. This is our third annual Women in Wellness, and I just love that we've all come together to learn together from our colleagues about things that matter for our wellness. As you've heard, our patients really do have the best of both worlds. We have the huge resources of Mass General, as evidenced by our colleagues here tonight, and we have local, high-touch, recognizable Nantucket Cottage Hospital in its newest version of itself, which is so beautiful. And it's very important to us to create a healing space working with Diane and Faith Frable and our colleagues in Boston. I want to especially recognize our event chair and the driving force behind this event, Meryl Braylauer. Where are you? Thank you for all you have done for women and wellness in so many senses, and especially for this event. And in addition, this year's co-chairs, Gail Camelier, Deborah Lewis, Carolyn McKenzie, and Mary Tafe. Thank you so much. You have all been wonderful, as well as the entire host committee. And last but not least, our trustee, Melanie Sablehouse. Thank you, Melanie. I'm going to thank my colleagues from Mass General, Vickie Jackson and Schwalm. And I was thinking about what they have really shown us this evening. And one of the things that I loved was that it shows the power of collaboration and that we are greater than the sum of our parts with the resources in Boston and what we have here that Diane brings and Faith and the extraordinary capacity that we have to leverage that both in the future for Nantucket and our islanders. I also loved the message that on the one hand, the technical capacity and ability of medicine is extremely important, but so are the healing arts. And the greatest opportunity for wellness comes in having both. And I really think with our extraordinary new facility, one of our opportunities is now to really turn towards looking at the healing arts and wellness, and that's what today is about. I wanted to give you some examples of what we're doing apart from our collaboration with Diane and her team for wellness on Nantucket Cottage Hospital. I'm very aware of completing the site right now because you may have seen we're a little bit of a mess, but one of the things that we are going to be seeing there are 3 gardens that are going to bring another dimension of wellness as we have with other aspects. We have music, for instance, in our lobby and so forth. But we have a Serenity Garden that was donated by the DeWitt Minus family who began the hospice and palliative care program on Nantucket. And that Serenity Garden will be a 1/4 acre with a sculpture and an area for people to sit and have sandwiches. And we may have some concerts out there, and it will be you will be able to see it from the respite room that you may have seen, which is a beautiful space in the hospital. We also have an area that the Nantucket Garden Club is going to create to the left of what will be the main door portico around our flag, a flagpole. And then we have an opportunity that I find very exciting. Do we have the picture of the labyrinth, the slide we could put up? Which is we have a space that is big enough for us to put a 27-foot diameter labyrinth. And I don't know how many of you know what a labyrinth is, but it's a classic, centuries-old pattern of a walking trail on the ground that is a way that has been found over centuries to create a kind of mind-body wellness, to still the mind and still the body. It's not a maze. You're not tripped up by making the wrong choices. It's a way of perhaps thinking of an analogy of life, that it's a path that meanders, but it's always going to the center. And it starts on the outside, and you can't get lost. And you always get to the center. And there are labyrinths that are ways, especially for the Western mind, of having a contemplative experience without having to sit in silence, for example. And you can just walk quietly, and you see them in many hospitals, many schools and prisons and churches. And here are some examples of some of these shapes. One is from Chartres in France, and there are many examples of them. So we have a potential opportunity to create a labyrinth as a message. It's both beautiful, it's a garden to sit in, but it's also a message about another aspect of wellness, which I think has been expressed here tonight, and I appreciate it so much. Thank you. So now I'm going to turn it over to Melanie Sablehouse.
Thank you, doctors. We had some powerful information, and I can now have a drink tonight and feel okay about it. You know what I mean? But I want to ask you this question, because this is really important to all of us, and that is the information that you received today from our entire team. Has that empowered you to make better healthcare decisions for you and your family? Has it? Good. That was our goal, and that was our mission. Margot, we are very excited about your vision with the Labyrinth Garden, and it's something I know that means a great deal to you. We would like to be part of its creation. A couple weeks ago, just so you all know, I might be catching you off guard, we got together, the committee and the co-chairs, and we said, wouldn't it be incredible if we could name this garden the Women and Wellness Labyrinth Garden. Be pretty incredible, wouldn't it? Your dream would come true. We would have a place where we could go as a community, whether they be a patient, a family of a patient, community member. I could have been in that garden on Sunday when 15 sable houses left my home after 4 days. 20 loads of wash. I needed the Labyrinth Garden at that time. But so we really would love to be part of it. So here's what I'm going to throw out to you right now. We're going to give you an opportunity at this moment, if you would like, to be a founding member of the Women in Wellness Labyrinth Garden. It's going to be very, very special. We can have a cocktail party there. I'll have my one drink. We can enjoy it. We can celebrate it. We can bring our family.
You can have 2 drinks.
And Labyrinth, 2 drinks. I'm in big. So what I'm going to ask you, is there anyone here at this moment, and we'll be giving you a little card if you would choose to fill it out. You do not have to invest. We're going to inspire you, hopefully, to invest, to make a commitment to be part of this Labyrinth Garden. So we'll have that at the end of the evening. Is there anyone at this moment right now that would love to invest $1,000 in this Labyrinth Garden in this room right now? Is there anybody? Oh my gosh, keep those hands up. Look at this, ladies. Our goal is $25,000. We have 7, 8 right now. 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, Margot, 18. Oh, ladies, thank you. Make sure you fill those cards out because we're almost there, all right? That is, wow. But I don't want to leave anybody out. Is there anybody, and again, we're not putting any pressure on you, but if you'd love to do it, is there anyone at $500 that would love to be part of our Labyrinth Garden? $500, anybody? 5 and 5, there's 1,000 between those two. Anybody else at 500? Anybody else? There's another. 250, let's go, another 500. You're keeping you up at 500 right there. Okay. Is there anyone at $250? $250? Anyone? Thank you, thank you, thank you. Listen, I think we've made it. I think we've made our $25,000. This is our garden, Dr. Hartman. You know, we started a great partnership. The Carps led us to this magnificent woman by the name of Stacy Boyd, this entrepreneur, this dynamic woman who came up with the concept, and it's Olivea. You've probably seen it at 25 Center Street, luxury, fabulous, beautiful accessories. And here's the exciting part about it. Stacy's whole platform is when you buy something at Olivea, she invests and contributes back to the hospital, to our operating fund, 20%. Ladies, it's shopping with a focus or guiltless shopping. And the interesting thing about it is that little lobe that he showed, it's really bigger than what he showed, the shopping lobe. And it makes you feel really, really good when you know that you're making a difference. And here's the great part about it, is that you can shop 365 days a year, and 20% of that, when you buy gifts for yourself, for your daughters, your daughter-in-laws, it all goes to the hospital. So, Margot, I'd like you to come up here because we have a really big presentation to make. Would you please come up? Stacy Boyd, would you please come up? Stacy?
Thank you, Melanie. So 3 years ago today, I was in a very different setting. I was in Dadaab, Kenya, which is the world's largest refugee camp.
Talk over here.
With Malala, the world's youngest Nobel laureate. Stepped off the plane and met this incredible group of young women, all of whom were receiving a distance education through Vodafone. I reached into my bag, take out my phone to take a picture of this incredible group of young women, and I realized that a fraction of the cost of my bag could send a girl to school. 2 years ago, I launched Olivela that Melanie described. We work with 400 luxury designers, Givenchy, Dior, Stella McCartney, Jimmy Choo, and partner with international, national, and local organizations. A year ago, I met Dr. Hartman and the incredible Carts and Kate and Melanie and a host of others, and we decided that 20% of all of the purchases, both at our Center Street location, corner of Center in India, and all of the proceeds from olivela.com/NCH would go towards Nantucket Cottage Hospital. We launched it at the end of August, so at the very end of season. But thanks to all of you in this room that have shopped either online or at the store, we have a $61,000 check for Nantucket Cottage. Woo! Woo-hoo! And again, the thanks is really to this room because it is the shopping that you're doing that's making that happen. So a round of applause for each of you. Thank you. Stay right there.
And that beautiful dress is from Ollie Vela. Right. Thank you. Thank you.
Would you stay here for 1 minute? Sure. Okay. You know, life on this island, 30 miles out to sea, as our doctor always says, it's the reason it all works is because of the fabric of the people here, the beautiful people on this island. There are certain people on this island that go that extra mile, that really make it significant. Well, there's a woman that's standing right over here behind me, is a woman that's gone thousands and thousands and thousands of extra miles, and she has changed Nantucket history. Yeah. She has worked for 20 years on this island. She came on and she was in the ER. You would see her with any of your emergencies. She then transformed into our CEO and has been the guiding light for this entire community and hospital for the transformation of this magnificent state-of-the-art debt-free hospital that we cherish, our NCH. This woman right here is going to stay on because she is going to tutor and coach the new CEO because she is retiring September the 1st. Now, that made me sad too, because she is a woman that loves this island, loves our hospital, is committed to so many different passions. She will never be gone. I will always think of her at the Pops in line, talking to every single person as they waited with their coolers, to get in, because this woman cares that much about all of this. So, Dr. Hartman, on behalf of every single woman and a few men that are in this audience right now, we'd like to present you with the beautiful bouquet of flowers and say we're grateful to you, we will never forget you, and God bless you.
Oh, my goodness. I'm grateful to do what I love in a place that I love with this kind of community and these colleagues. Thank you so much. Thank you.
What a great note to end on. I'm Carolyn McKenzie, one of the co-chairs, and I just want to thank you all for coming to this third annual Women in Wellness seminar. In an email, we're going to reach out to you for your feedback and to see what kind of topics you'd like for another year. Integrative medicine, plastic surgery, sex, you name it. And we're going to make next year's seminar to fit your interests. At this time, I just want to invite everyone to go upstairs to continue their discussions with the doctors who will be there to answer questions, except for one. Yeah. And to have a nice drink and socialize and some hors d'oeuvres. And again, many, many thanks for all your support and for coming today.